cell protects the graft from antibody-mediated immune injury. Single-center experience in living donor renal transplantation. Please.
Thank you very much for the chairpersons. At the outset, I would like to thank the organizers for giving us the opportunity to share this experience about stem cells in transplantation. And all this work has been done under the mentorship of Professor Trivedi, who's sitting here in the audience. All of you have been listening to different aspects of mesenchymal stem cells and the stem cells. Today I'm going to touch upon the different part of mesenchymal stem cells, that is how to overcome the DSA effect on the graft. As all of us know, the UNOS data has shown that whether it's living donor or diseased donor transplants, in the living donor, the half-life, like 10 years survival is 68%, and 1 year is 95%, whereas in diseased donor, it's 89% survival and 10 years is 51% survival. This all has been done with triple immunosuppression and all kinds of powerful immunosuppression. That means whatever you do, whatever immunosuppressants or modulators or induction therapies you lose, half of the grafts are going to be lost to chronic graft attrition. And now it's kind of a consensus that most of it is lost because of donor-specific antibodies. We have been trying to deal with that aspect, and in search of the utopian dream or the holy grail of transplant tolerance, over 15 years we evolved a final protocol in which we have used mesenchymal stem cells, and now with less than 2 immunosuppressants, and some of the patients are on 0 immunosuppression, we have evolved this protocol. Our 5-year survival is 95% patient survival, and graft survival is 84%. That too is on 2 drugs or less. And we were trying to analyze what are the reasons for our success. The first is we delete the rejecting cells right at the beginning of the whole protocol. So whatever the enemies are there, we first clean them off before we start out. And then we give combined adipose tissue-derived mesenchymal stem cells and the hematopoietic stem cells into the liver and thymus. Liver being tolerogenic and thymus because that is the central academy of tolerance. So then nothing is going to be rejected. And of course this we do under a very safe non-myeloablative conditioning. And of course at the end is what we get is a stable graft with generation and recruitment of Tregs. So these do all the policing and they control all the rejecting cells. And this is of course our study design where we delete out with using the TLI and the rabbit ATG, and peritransplant is bortezomib, and we put the stem cells with the 3 immune modulators, that is the lymphocyte cross-match, the flow cross-match with the T and B cells, and the single antigen with the Luminax platform. And I was looking at our data, and I took up 138 patients. The mean age of 32 years and mean HLA match is 2.6 years. And we were trying to monitor serum creatinine reflecting the graft status, DSA to reflect if there is any antibody which is going to cause antibody-mediated rejection, the peripheral blood chimerism to show for the grafting of the stem cells, and of course the Tregs for immunomodulation. Interestingly, what we saw is that chimerism does not have any correlation with tolerance. We have plenty of, like hundreds of patients living a normal graft, normal life with no immunosuppression in spite of absence of chimerism. On the other side is a huge load of patients who are having a normal graft in spite of the DSAs. So these 138 patients, the total mean quantum of stem cells infused was 273 ml, with a mean CD34 count of 2 billion cells and the mesenchymal load of CD45 90 plus and 73 plus of 4,000 and 7,000 cells per kilogram body weight of the patient. None of our patients has ever had any adverse effects of either the stem cell infusion or the conditioning. So there should not be any fear or worry about the mesenchymal stem cell infusion, provided you put them before the transplant. And of course, we have never lost a single patient of the graft so far. We have now the experience of about 1,500 patients. This is just to show a typical case. Like on the top, you can see that this is a lady, 29-year-old lady, transplanted with a father's kidney in August of 2010. This graft was prepared on 10th of June this year, and so now it is about 3 years post-transplant. On the top is the HLA match. This is the patient and this is the donor. And this visit traffic shows the single antigen. This is x-axis is showing the time induction in days since the patient was taken into the protocol. On this side is the single antigen measuring the Luminax, the donor-specific antibodies, and this is the serum creatinine in milligram per dl. As you can see here, there is absolutely complete control of the antibodies all across, and the serum creatinine now is about 0.9 on no immunosuppression, and the protocol biopsies 3 times were performed, all were normal. This is the last biopsy performed 2.5 years after, and we saw a few Treg cells, FOXP3 positive in the graft, and granzyme negative. However, every case was not like this. So we divided out the 2 groups. One was those who had DSA positive, and the second group where there was absence of DSA. In the group with DSA positivity, the 90 patients, the follow-up of 6.5 years on 2 drugs or less. Mean age is 32 years, their serum creatinine is 1.43. 33 patients are on no drugs or 2 drugs, or on just spread, and 57 patients are on 2 drugs. Whereas on this side of the graph, with absence of DSA over the follow-up of 6 years, the age is 32.5 years, their serum creat is 1.4, HLA match is about 1 haplomatch. We have 56% patients on low dose of PRED or no immunosuppression, and 44% on 2 drugs. This is a typical graph, again explaining the same thing. All kinds of donor-specific antibodies here, but 3 times the graft biopsies were performed. All of them were normal, and serum creatinine as of today, 5 years post-transplant, is 1.9. Once again proving, but because of some traffic here, and for security, we added 5 of PRED and mycophenolate sodium at this juncture. And these are the different protocol biopsies of all these patients. Whether it is DSA or no DSA, they all look normal. This is another case again which was recently published in the BMJ showing the same thing, serum creatinine around 1.1. She is just on 5 of PRED. It's now 4 years post-transplant, normal biopsy, no effect of the DSA. So why did this happen? The reason is, whether it is DSA or no DSA, it is a Tregs. With the absence of DSA, the Tregs are 3.5, and with the presence of DSA, it is 3.25. That means there is no statistical difference. What is happening is perhaps the mesenchymal stem cells, they get converted into the Tregs. So these go from the blood or periphery into the graft, and then they go to the lymphoid repertoire, and that's how they spread the infectious tolerance, and there's a linked suppression on the T effector cells. So that is how we have controlled all the antibody-mediated injury on the graft. So to conclude, DSA is believed to be detrimental to the graft in general, but if you put the mesenchymal stem cells and the hematopoietic before the transplant, then the graft will be protected by the DSA-induced injury. And in the end, I would like to say that stem cell infusion helps in minimizing the immunosuppression. Thank you so much. Yes.
Thank you for an excellent presentation. Congratulations on your result. I have a quick naive question. Why did you select the 2 types of mesenchymal stem cells?
Yeah. In fact, we have published the data of comparison of mesenchymal and the adipose mesenchymal plus hematopoietic and hematopoietic alone. With the adipose act, they get into the scaffolds and they help in tissue regeneration and immunomodulatory effect. The bone marrow hematopoietic alone are not so effective immunomodulatory and tolerogenic. So it's a combined thing which helps out.
Okay.
This paper I published in the transplant proceedings, the comparison of the 3. The control patients, adipose plus hematopoietic and hematopoietic alone.
Could you make some comments on the donor stem cells, also autologous stem cells?
Sorry?
The stem cell source.
It is from the kidney donors. All of these are from the kidney donors.
Yeah, I know that. I said it's a stem cell, mesenchymal stem cell source from
the adipose tissue.
Yes.
We take from the adipose tissue by resection from the abdominal pad of fat. We take about 10 to 15 grams, and that's processed in the lab, and then we make mesenchymal stem cells out of those fat.
Yes, I understand that. I said it's, I just want to clarify myself.
Yeah.
I'm talking about source from the mesenchymal stem cell from the recipient versus donor.
No, the recipient, what we believe is that the recipient himself or herself has some immune dysregulation. So we don't want to try out the same dysregulated mesenchymal stem cell and put into the already defective system. And we also want to create tolerance. So the system is taught that this is your own, don't reject it. That is why once we take the adipose tissue from the donor, then the recipient knows that this is not our enemy, let us keep it. So that's why there's two combinations.
If I understand well, the injection prior to the transplant would help somehow priming the immune system?
I didn't understand you.
Well, you use the injection of the mononuclear cells prior to the transplant.
Yeah, yeah, this is prior to the transplant.
Yes.
If I can
and then,
go back.
with the induction, probably for the intestinal
Yeah,
time.
it's in the protocol where
Yes.
we put it, yeah.
And then you use an induction after, so that the patient have been primed, and then you deplete. So
Yeah, so what we do is once the TLI is put, the gap is, the space is created, and in that cell, in that created space, the stem cells are grafted. And so, and then again, once we check out the immune monitoring by LCM, FCM, and the single antigen, if everything is clear, then the big antigen in the form of kidney is put in. But again, that's a big load. So to nullify the effect of even some of the cells from the kidney, it's covered, the rabbit antithymocyte globulin 1.5 is given at the time of anastomosis. So whatever antigen load is released, the RATG takes control.
Okay, thanks.
Thank you.
Just a question. Thank you very much for your excellent data. I'm not a clinician, so I just a technical question.
Yes.
Do you expand the mesenchymal stem cell by using a special medium?
Yeah, it's
with
our
a
own.
serum-free, or
Let me tell you, in fact, we had patented this technique, but then we gave it up in the service of humanity. We don't want to make money out of it, so we gave it up. Marie Curie didn't go for her radium thing, so we don't want to patent it. We had already patented it, but then we withdrew it. We realized that this is in service of humanity, we should not make money. It's for welfare of the patients. They should live a normal, healthy, happy life with no immunosuppression. So we have our own technique. It is xenogenic free material.
Thank you very much.
Yeah. Thank you.
Thank you.